in the paper, and you put some technologies in the implementation ready bucket and others in the promising confirm local bucket. How do you explain the difference in maturity to decision makers who hear AI for cancer screening and just assume that everything is ready to scale?
Yeah, and that's something we hear for all kinds of things. When people talk about AI, it's so broad that it's really hard to grasp what is important and what is less relevant to what we're trying to accomplish. So one of those components is levels of maturity, so things that have been already been proven in the field that we know it works. So for example, doing the assessment of cervix with cameras, we know that that's something that we have done for many years, and that even the WHO in constrained settings is proven to actually show the benefits. But things that are more still up and coming, like using clinical trial matching, for example, which I'm very passionate about, and I want this to be the pre-screening hubs need to be something that's scalable everywhere. I think still need to prove it in different settings. So not only in the U.S. but in Latin America, in Africa, in Europe, all those have different frameworks. So those levels of maturity is something that we always need to assess with any new tool that come our way, and that also sets the governance because we don't need the same level of scrutiny, for example, for an ambient AI scribe that is just listening to the conversation the same we're having today, and something that is more really focused, like cancer detection or having something that is going to be clinical decision support. That could be very important because that can lead to biases if we don't have appropriate levels of maturity.
Mm-hmm. You highlighted AI assisted mammography. We talked a little bit about HPV, AI supported lung CT, such and tools such as that being validated locally before being broadly rolled out. For a hospital thinking about those imaging AIs, what bar should be set before deploying them in routine screening?
Yes. So models that have been done in this case, they are so contextual to the population that will be deployed. And the onus is not on the developers of those solutions because it's almost impossible to create a customized solution for every single setting. Is the responsibilities upon the governance of that implementer. So in the United States, for example, for mammography, we have to do clinical trials. Because we have very large data from Europe, for example. There's a study called the Masai trial where did the assisted mammography and 100,000 patients, and we knew that actually works. But the breast density and the population that we have in the U.S. is completely different. So cannot be certain that that population is equivalent to the United States. So always look at when you look back to checking the cereal box and see what vitamins and how much fiber it has. We need to have the same level of scrutiny on the models and make sure that we are accounting for the population that we serve.